Hello, I'm Tracy Finch and I'm Professor of Healthcare and Implementation Science at Northumbria University, and I lead on implementation science and knowledge mobilisation in North East and North Cumbria NIHR ARC. Today, as part of the ARC's virtual college, I'd like to share ideas on normalisation process theory as an approach that can be helpful in complex interventions research. Normalisation process theory, or NPT, explains successful and unsuccessful implementation processes with reference to the extent the practices become routinely embedded. So it aims to address the question of what needs to happen for a change in practice to become routine. So NPT came about through primary research across a range of programs of work that involved observing changes in practice around different kinds of technologies and interventions, and through working with collaborators from different disciplinary and practice backgrounds. We describe NPT as a theory because it focuses on the explanation of what influences implementation outcomes. The best way to think about NPT, though, is as a way of thinking about implementation problems that focuses on, firstly, how interventions do or can become part of everyday practice, and secondly, how different groups of people work together to achieve this. So for the NPT, the overriding question is, what is the work here that needs to be done? From the perspective of NPT, four kinds of work need to happen. Firstly, there needs to be coherence, so it has to make sense to those involved. Secondly, cognitive participation is key, so this is about people being engaged and investing in the process. Thirdly, people need to act collectively, so they need to be able to do the necessary work to make it happen in practice. And we all know that interventions have unexpected effects that need to be managed as they happen. Finally, and because implementing and embedding changes in practice require sustained effort over time, those involved need to be able to appraise and act on the observed effects of their efforts, or in NPT terms, engage in what we call reflexive monitoring in order to normalize new practices. So at its most basic level, NPT is all about the work. What is it? Who does it? How does it get done? And why did it happen like that? So I'll say a lot more about what NPT might be useful for throughout the session, drawing on examples of how we have used NPT in a number of different ways. But I'd like to start by bringing our attention to the MRC framework for complex interventions and use this as a structure for the talk. For those of you who are familiar with this, you'll be aware that there is also a more specific set of guidance around process evaluation that's linked to the framework. And I'll later show examples of using NPT in a process evaluation of a trial. But let's start by thinking more broadly, as I'd like to show how NPT, as a theory of how change happens and becomes embedded, might inform elements right across this framework to include developing interventions, exploring feasibility, evaluating and implementing them. Through the talk and in relation to the different elements here in the framework, I hope to show how NPT might contribute to answering the questions that are positioned as core elements in this framework. So using it to explore how interventions interact with context, how different perspectives can be included, and how interventions could be made better. In 2018, we published a review that included 108 unique studies that had used NPT as its primary theoretical approach. At this time, 73 studies were process evaluations, and almost all used qualitative methods. And I'll cover some of this today, but as an overview, NPT can help with planning and developing new interventions, evaluating interventions, or rolling out proven interventions, so developing implementation strategies. The Murray et al. Paper from BMC Medicine shown here is really great as a place to start for further information and examples of how NPT can be applied in these different ways. But first we'll start with taking a look at how we might use NPT to develop or identify interventions. An example of how NPT might be used to develop an intervention or plan its implementation can be seen by the NPT toolkit that we have on our NPT website. The toolkit has 16 questions presented in this format, and there are 4 questions addressing each of the NPT constructs. These questions can be scored by moving the bar across from none at all to completely. And to show some examples, question 11 on collective action prompts a discussion about how work is allocated under a new assessment pathway. The comment shows that not all staff working with the pathway have acquired the necessary skills yet to make full assessments. So discussion about question 15 from the reflexive monitoring construct highlights that staff currently don't have access to any feedback about the impact of their efforts, and that addressing this might suggest a strategy to improve engagement. So what's key here in terms of the toolkit questions is not the scoring as such, but the thought processes, the analysis and discussion that the items generate around an implementation activity. So there are different ways to use this tool. For example, it could frame a group discussion involving professionals with different roles in relation to the intervention, or it could be answered for different groups separately and then compared. It could be used early in an implementation process for planning, or later on when evaluating or reflecting on reasons for success or failure of that implementation project. The example of the online MPT toolkit hopefully gives an example of how MPT thinking can inform planning and development work, and or be used in a very informal way to open up discussion of what might be the key issues that need to be planned for. In this study, led by my colleague Michael Sykes, MPT was used in a number of different ways to inform the design of enhancements to audit and feedback in relation to care of persons with dementia. This was an in-depth co-production study undertaken across 6 hospitals in the northeast of England to firstly gain a rich description of current audit and feedback processes, and secondly, to develop enhancements to those processes, which were aimed at improving the likelihood that feedback would be acted on in ways that lead to improvements in care. Throughout all stages of the project, Michael facilitated and worked closely with a co-production group and academic advisory group that met several times throughout the process. I wanted to show this as an example of how evidence, primary data, theories and frameworks can all be used to robustly develop, with stakeholder engagement, an intervention to improve care. MPT was one of the overall theoretical approaches for the study, informing the data collection and analysis in the descriptive phase, and then more explicitly in relation to the intervention, which here is an improvement intervention in the form of a strategy to implement enhancements to audit and feedback. In the intervention development phase, for example, Michael used the MPT toolkit to frame one of the co-production workshops, having participants score and discuss potential strategies for enhancement, and then consensus methods to settle on what to focus on. But I wanted to give this example to make a particular point. MPT can and should be used alongside other theories and approaches. Here, for example, MPT has informed some of the more process and organizational elements of the intervention, alongside the theoretical domains framework from Michi et al., helping to specify behaviourally focused strategies that also form part of the intervention. This intervention, which we call the Quality Improvement Collaborative, or QUIC, is now being delivered as part of the National Diabetes Audit, and we have been funded by NIHR to evaluate it. So if you're interested in that, do look out for more on the Equipped study or contact Michael, who's leading. Whether using qualitative or quantitative approaches, MPT acts as a sensitizing tool to ask questions in relation to the 4 MPT constructs, thereby enabling understanding of mechanisms of the change process. So I'm going to move now to focusing a bit more on this. One study, which I think is a good one for showing the use of MPT in some different ways, but particularly as part of a process evaluation in a randomized control trial, is the STRIDE study. In STRIDE, we developed and evaluated the effectiveness and cost effectiveness of a cognitive behavioural therapy-based intervention for fear of falling in older people living in the community. And this intervention aimed at improving self-efficacy for not falling. We included an embedded process evaluation in the trial. In STRIDE, we used MPT both for intervention development to help hit key MPT targets of making sense to the people involved, facilitating participation, etc., and also for the qualitative evaluation. But I'll focus today on the latter. So we undertook interviews and observations right throughout the project with all of the different participating groups. And you'll see some more in a minute on the next slide, including even members of the intervention development and trial team. And often those kinds of interviews can bring a lot of insight into some of the more practical implementation related challenges of any intervention. So this is taken from the summary of our interview schedules, and I'm just showing you the part here that is about the collective action construct of MPT. So this section is all about things working in practice. So not all questions were considered relevant to ask of all of the groups, but where some of the questions were relevant to multiple participating groups, this really allowed us to explicitly explore differences in experiences and perspectives. I'm skipping forward a bit here because this is the summary of our discussion chapter, or what you might call a higher level analysis framed by MPT. I couldn't find a visual to show our coding framework, but the data transcripts and field notes of observations were coded thematically initially and in a very inductive way, so without reference to the MPT constructs first. This was important so that we didn't impose limits on key issues emerging that may not relate so clearly to the MPT constructs. I'm not going to elaborate on these findings in detail, but the later mapping of these against the MPT constructs shows that we found evidence of different levels of MPT's proposed conditions of what we call normalisation of the CBT intervention for some groups than for others. The project team had to work to develop coherence for some of the participants, but many of them, they did get it. They got the concept of CBT, and some less so. In terms of cognitive participation, engagement and commitment was generally high and certainly key to the successful completion of the trial. Collective action assessment showed lots of challenges, including in adapting the CBT to accommodate the multiple comorbidities and the different challenges that the clients experienced alongside the fear of falling. But also adaptive processes and responses from those involved to help it work. In terms of reflecting and appraising, some participants were in a better position to benefit from that than others. For some clients, the skills taught were internalized, they became part of what they did and sustained beyond the intervention period, whilst others showed a need for more ongoing support. So going forward, these findings could be used to inform modifications to the CBT program and/or its delivery in the service setting. So the trial itself actually showed a positive effect, and levels of self-efficacy for falls improved for intervention participants relative to those in the control arm. What the MPT informed process evaluation did was allowed us to see kind of a bit more about what worked and why, and with which people. I'll move on now to consider how MPT might help us to think about outcomes as part of complex interventions research. In thinking about assessing outcomes of a complex intervention study, I wanted to start here by illustrating why paying close attention to reflecting on whether and how things are working is not only a core element of MPT, but also important for implementation and improvement work in practice. And this quote came from a study of quality improvement collaboratives for tracheostomy care. The collection of data here served two different purposes. It was there for the evaluation of the intervention, but it also had a much more practical use in improvement work. Much of our initial work in developing and then using MPT involved qualitative research, and that I think was reflected in the systematic review from 2018. But well before that, we decided to work with the MPT constructs to develop and validate a survey tool that could allow MPT to be more easily used in quantitative research, including for use in assessing the progress outcome of implementation interventions. And in 2012, we started a study funded by the Economic and Social Research Council, and that's the NOMAD study. Now, I can't describe this development process in any real detail, but it took around 2 years before we did the validation study just to develop the survey. And this was an iterative cycle of item generation, workshops, cognitive interviews, and Delphi work using consensus methods to develop a survey tool with strong face validity to users, balanced with strong alignment with the theoretical constructs and more detailed sub-constructs of normalization process theory. So we developed a set of 43 initial construct items for validity testing, which we did in 6 different implementation studies before reducing the survey to 20 construct items as a final set, and that is what is in the published version today. And just a quick illustration here from the set of items for coherence. You can see that it's designed with a Likert scale of agreement, and the intended respondents are generally those who are involved in some way with an implementation process. And the items are expected to be modified to refer explicitly to the target intervention or program that's being implemented. So we suggest that what NOMAD measures is implementation processes from the perspective of individuals involved in implementation activity. So it's their perception of what is happening and what progress is being made. For those less familiar with quantitative approaches, analysis can be undertaken on survey items to explore the statistical relationships amongst those items, to determine if the item sets represent the theoretical domains that you've intended to create. In our study, the factor analysis results did show support for the intended theoretical structure, with good results for internal consistency of the construct subscales, as indicated by Cronbach alpha reliabilities. And similar results have been replicated in other studies, including with language translated versions in other countries. So there are versions of NOMAD in the Netherlands, in Sweden, Germany, and a whole host of other countries that have had similar validation work completed. A lot of complex interventions research involves mixed methods, so putting quantitative and qualitative approaches together. And one of the studies we've used since developing NOMAD is this mixed method study of the implementation of acute kidney injury alerting on hospital wards, undertaken here in the northeast of England by colleagues including Jason Scott and others. AKI alerts have been introduced into hospital wards as mandatory as a measure to improve safety and early recognition of patient deterioration, but with limited evidence of their effectiveness on outcomes. Our study focused on understanding how this is implemented and engaged with in practice from the perspectives of the different professionals providing care in these settings, using observations, interviews, and NOMAD surveys. And here we have one of Jason's lovely petal charts, or sometimes these are called radar plots, that can be generated through Excel, showing how mean scores compare across items and between MPT constructs. In general, we see that levels of collective action have been reported fairly favourably compared with other constructs and with particular items in this study. NOMAD scores alone provide an indication of where there might be issues, but not really what explains those poor ratings. So combining these with qualitative data helps us to build a better understanding. For example, here, low scores on the initiation subconstruct of cognitive participation indicated a lack of preparation of staff to work with the alerts, which might have included, for example, training. Combining the NOMAD data with the qualitative data in this study allowed us to summarize a description of an explanation for how and why AKI implementation was not as optimal as it could be, with reference to coherence, cognitive participation, collective action, and reflexive monitoring as mechanisms for embedding changes in practice. So in relation to MPT and its focus on collaborative collective work, one interesting finding was that in relation to collective action, staff tended to respond to and work around the alerts more independently and less in relation to each other, than we might have expected. And some of this is about different people coming and going from the ward at different times, and having different roles. So it really highlights what's actually happening in the process. There is more guidance on the NPT website about how Nomad might be used in different studies and how it can be adapted. But just a note to say that that's only guidance. There's a lot of scope for using the survey in the way that suits your project. So although validated for the wording of the construct items, and we advise that those core items stay the same or as close as possible to the originals, we also encourage tailoring and adaptation of its use so that it fits well within the particular study and with that study's aims and purposes. And at present, at the time of recording, there's an issue with the original Normalisation Process Theory website link, and I show another link elsewhere that could be used at the moment. So we're working on those problems at the moment. So to quickly sum up this section on using NPT to build an understanding of an implementation process, in complex interventions research, NPT can help with expanding your focus, giving it some breadth, or giving extra detail to an aspect of your investigation by acting as what we call a sensitizing device in data collection. It can help you to write topic guides, for example, for interviews. Secondly, it can provide a conceptual lens on the data through serving as an analytical device. So once you've collected data, it can help you to make sense of it. And it can also, thirdly, provide an organizing structure for describing your findings. So sometimes you have lots of different data collection in a bigger program of work, and it can help you to pull that together and communicate it at a higher level. And just a tip is to say that using it in qualitative research doesn't mean that you need to constrain the data in any way. Often the best qualitative research using NPT starts with a much more inductive approach to the data in the first stages, and then using the NPT to make sense of that data. So far, this has all been about NPT, but it's important to say that NPT isn't everything, and it's not the answer to everything. So I'd like to say a few things about going beyond NPT and using it alongside other approaches, which is something that is often a good idea. In complex interventions research, and certainly in implementation research, behaviour change theories and approaches are commonly used. So these include things like the theoretical domains framework and the behaviour change wheel. Increasingly, I'm seeing these approaches used really well alongside NPT, where it's clear what each theory or approach has to contribute to the overall project, whether that's in relation to intervention development, evaluation research, or development of strategies, etc. And Michael's quality improvement collaborative intervention that I described earlier is an excellent example of this bringing together of approaches that bring different value and purpose to a project. And within an evaluation study in particular, both approaches can inform data collection. So a qualitative topic guide can have questions informed by both approaches. And to give a brief example, here's another locally conducted study by Jill O'Neill and colleagues in the Northeast, who developed and evaluated a brief intervention for screening for alcohol in the hospital outpatient setting. And this was undertaken in endoscopy units. So here they used the NPT for insight into factors affecting the organizational embedding of the brief intervention. And they used the theoretical domains framework, or TDF, for more change techniques focused on the behaviour of professionals. They found that it was possible to reach a high number of patients in a busy hospital outpatient department and deliver the brief interventions by working with staff using these frameworks for training. So combining the theoretical frameworks allowed for more of a multi-level approach to embedding. So factors relating to professionals and their behaviours, but also the necessary collective work at the level of the clinic or service provision that needed to happen for this intervention to fit in. MPT has also been combined in studies that have also applied realist evaluation approaches. So some of you have likely heard of realist evaluation, and in general, this is a methodology that's applied in research where the focus is on understanding how an intervention works or not, in what settings and for whom. Realist approaches involve identifying contexts, mechanisms, and outcomes, and specifying relationships amongst those elements in the form of program theories. For example, set out as what you can see on the slide as CMO configurations. And then those approaches would test and refine the CMO configurations with empirical data. So MPT is similarly focused on understanding mechanisms of change with reference to how that happens in context. So together with realist evaluation expert colleagues, we undertook a systematic review of 8 studies that had integrated the 2 approaches with a focus on how they had integrated them, what each approach contributed, and what methodological or practical reflections the authors could offer. We found that overall, realist approaches were the main driver in these studies, and that MPT was most commonly reported to have added some extra explanatory power to the different elements of the CMO configurations, but especially in relation to the element of mechanisms. So as noted, there's some common ground already between realist evaluation and MPT. Both focus on action in context and on developing understanding of mechanisms leading to outcomes. But they differ in that MPT is a theory with no particular specification of method, whereas realist approaches can be described more as a methodology that has a particular conceptual focus. So thanks for bearing with me. I'll move to summing up now. And if there's a general message to take away from this about what MPT can tell us about implementing and sustaining change, it's this. Implementation work is complex and involves ongoing efforts to achieve sustainable change through building understanding of the work that it requires. Also establishing and maintaining the participation of key persons involved and ensuring that participants and organisations have the means of appraising and adapting, where necessary, the work that has to be done. So if we come back to the MRC framework, I'd like to suggest that across the different phases of work in the framework, MPT can help us address, at least in part, much of the questions being asked in relation to the framework's core elements there in the middle in the red box. It directs us to pay more attention to and understand better the context in which the intervention is being provided. It provides a theoretical lens for developing theory around how the intervention works and how it might be developed or refined or improved. It helps identify uncertainties and challenges around a complex intervention. It lends well to stakeholder engagement work as it focuses entirely and explicitly on how groups of people work together. And it can directly inform work around intervention development and its delivery in practice. While not explicitly intended to address the economics of a complex intervention, the understanding of process and impact that can be gained from using MPT can inform economic analyses by demonstrating, what is the work involved, how much of it is there, and who does it. And this is now a developing area within the field of implementation science. And finally, these are the top tips that I'd suggest in using MPT. MPT is all about understanding and addressing issues of implementation. So this is about going beyond description towards developing explanations. Secondly, as a theory rather than a method, MPT has some flexibility in how it can be used. It can be used through a range of different tools, such as topic guides, surveys, problem analysis, evaluation, whichever way suits your project. So making it at home with your particular project is key to it working for you. Thirdly, MPT helps us to focus on how the work of implementation happens across a range of people, situations, times, and places. It's not focused on changing the behaviour of individuals, although behaviour is important in any implementation process. NPT helps to make sense of how people work together to implement change within the context that they're working in. But NPT is a theory of implementation and not a theory of everything. And it approaches the problem of implementation in line with its own focus. In implementation research, it can and should be used alongside other approaches. Thank you. And thank you very much for listening today. This session was provided as part of ARC Northeast and North Cumbria's virtual college.